it. Okay, good. Okay.
Okay. Hello everyone, and I'm Dr. Zheng Qian and came from Guizhou province of China. And today I will share a patient with progressive weakness and muscle atrophy for 5 years. And this patient is a 27 years old male, and he was admitted to our department after he complained of progressive weakness and atrophy in the 4 extremities for 5 years. When he was 22 years old, he manifested difficulty in climbing stairs. As time progresses, he complained of progressively increasing weakness. When he was 25 years old, he developed muscle atrophy and weakness in the 4 extremities. In the following years, his weakness and atrophy progressively worsened. This patient was born to consanguineous parents, but did not have a family history of neurological disease. So this picture is the pedigree of this family, and this black field symbol is this patient. As for the physical examination, which revealed muscle atrophy in the shoulder girdle, paraspinal regions, and the 4 extremities, and muscle hypertrophy occurred in biceps brachii. Muscle strength in the 4 proximal extremities was grade 4, and other systemic examination was normal. So this picture A, we can see the atrophy of the upper limbs and the muscle hypertrophy of biceps brachii. So picture B, we can see the atrophy of the lower limbs. So as for the blood test, the blood biochemical test reveals that CK and CK isoenzyme increased to 1083 and 48.5 respectively. Routine blood test reveals that adenine transaminase, aspartate transaminase, and lactate dehydrogenase levels increased to 52.3, 58.2, and 331 respectively. And the other routine biochemical tests were normal. As for the electromyography results, picture A, we can see the mean time limit of the motion unit potential and the wave amplitude of the left tibial atlas arteria and left deltoid or decreased. And picture B, the pathological interference phase was observed during vigorous contraction in the left deltoid and the left tibial atlas arteria. So the electromyography results showed myogenic damage. And this is a muscle MRI. And picture A, we can see MRI showed fatty replacement involves the gluteus maximus. Picture B and D, or the MRI of the thigh, shows that the fat infiltration involves the semimembranous biceps femoris, longus muscles, and adductor magnus. So the picture C and E were the MRI of the curve level, which reveals that the fatty replacement involves the solars and median head of gastrocnemius. So we can say the muscle MRI of this patient showed fatty replacement involved many muscles. And whereas the localization of this patient showed progressive weakness and atrophy in the 4 extremities. And the physical examination revealed muscle atrophy in the shoulder girdle, paraspinal regions, and the 4 extremities, and the muscle strength in the 4 proximal extremities was grade 4. And electromyography result showed myogenic damage, and the muscle MRI showed fatty replacement involved many muscles. So the localization of this patient is muscular system. So as for the quantitative diagnosis, this patient is 27 years old. He showed slowly progressive course, and he was born in consanguineous parents. And there were low evidence of infection, metabolism disease, tumor, toxication, or medicine. So the quantitative diagnosis of this patient is hereditary. So as for the localization of this patient is a muscular system. So we perform the left biceps brachii biopsy. And picture A and B were the X-ray staining. X-ray staining demonstrates some regenerating fibers and fibers with few internal nuclei. So this one, and this one, we can see the fibers with few internal nuclei. In addition, it also demonstrates a large number of macros within male fibers, including some rimmed wrinkles. So we can see there are a large number of wrinkles within the male fibers, right? And also this one, and this one is the rimmed wrinkles. So picture C and D were the ORO staining. The ORO staining showed a great many of liquid droplets accumulated in male fibers. So in the picture, the orange red dots are the lipid droplets accumulation. So picture E and F or the AMIQT staining. The AMIQT staining comes from the rimmed wrinkles. So this is the left biceps brachii biopsy features. As for the quantitative diagnosis of this patient is hereditary. So we perform the gene test. So this picture is the single test. This is a single test of this patient, and this is a single sequence of his parents. We can see the single sequence of this patient showed a novel homozygous mutation located on exon 4 of PNPLA2 at this point. So the PNPLA2 sequence of his parents display a heterozygous mutation of the same genetic mutation. So picture B is the 3-dimensional structures of wide model and the mutated ATGL protein encoded by PNPLA2. And the homozygous mutation of PNPLA2 result frame shift and change your renin to glycine and premature stop protein and a mirror oscillator position 178. So, and this print, the white arrow is the initiation mutation position of a mirror oscillate. And the picture C is the protein dominance of wild type. This is the wild type, and the mutated ATGL protein of our patient. We can see a predicate transcript shows that our patient has lost 16 amino acid of the petating neck domain. In addition, the novel mutation results in the neck of the C terminus of the protein and the amino acid position 178. So based on the above result, we give the final diagnosis of this patient is neutral lipid storage disease with myopathy. So the neutral lipid storage disease with myopathy is a real disease. And about 50 patients in the world have been reported in the English written literature. And it is a real myopathy in an autosomal recessive inheritance pattern, which is caused by the mutations of PNPLA2 gene. And pathogenic mutations of PNPL gene will lead to neutral lipid storage in several organs. And as for the clinical features, most patients with this disease often present in adulthood between the second or third decade with a progressive myopathy with or without cardiomyopathy. Hepatomegaly, hearing loss, diabetes, short stature, and mental retardation may occur in patients with this disease. Muscles of the shoulder girdle and the posterior compartment of the leg are commonly affected. And bilateral biceps brachii muscle hypertrophy was observed in our patient, which has not been reported in patients with this disease. And one muscle MRI study shows that fatty infiltration in thighs and the lower legs were common phenomenon in most of the patients. In most patients, muscle atrophy and muscle fat infiltration on posterior compartment of the legs were observed. In addition, the muscles of lower legs were more severely affected than the thighs. This phenomenon indicates that the lower leg MRI may be variable to the diagnosis of this disease in early stage. So this is the MRI of our patient. We can see the muscle fat infiltration on the posterior compartment of the legs, of the thighs and the lower legs. Also, the muscles of the lower legs were more severely affected than the thighs. So the abnormal features of our patient were same as the study. And in the biopsy of skeletal muscle tissue, a large amount of lipid droplet deposition in muscle fibers is an pathologic feature of this disease. But pathology makes the diagnostic characteristics of this disease. Based on previous reports, REM varicose separates this disease from other neutral lipid storage disorders. So in our patient, we can see many REM varicose within the fibers, same as the previous reports. So to date, over 30 PNPLA2 variations have been reported in the literature. Our patient shows homozygous for a novel frame-shaped mutation in PNPLA2. This homozygous mutation of PNPLA2 results in a frame-shaped and a change of renin to cleansing and encodes a truncated protein that shared only with 178 amino acid of the ATGL protein. And as for the treatment, no specific treatment has been found for this disease. By the favorite lipid lower agent being used experimentally, but no measurable clinical benefit. Therefore, further study is needed to detect the effective treatment of this disease. So, in concluding, neutral lipid storage disease with myopathy is a real myopathy in an autosomal recessive inheritance pattern, which is caused by the mutations of PNPLA2. The common clinical features of this disease is progressive myopathy with or without cardiomyopathy. In addition, muscle fat infiltration and atrophy on the posterior compartment of the legs are characteristic of this disease. Moreover, biceps brachii muscle hypertrophy may occur in patients with this disease, and marked of lipid droplet deposition and massive varicose of various size with myofibers are the pathologic features of this disease. Also, muscle tissue biopsy has certain specificity for the diagnostic of this disease. However, gene testing is the gold standard for the diagnosis of this disease. And this is the references of my presentation. And thank you.